Okay, Ramesh. Uh, Ramesh needs no introduction. He is a stalwart in squint and pediatric ophthalmology. One of my favorite speakers and someone whom I really look up to. I wish I could do as good a job as he does in squint. But anyway, maybe I'll learn one of these days. Go to him and learn. So, Ramesh, over to you.
Dr. Ramesh, please start your video. Audience will like to see you.
Ramesh, you can share your screen.
Yeah.
Can you see me? Yeah.
Yeah.
Thank you so much, Dr. Sunayana and Dr. Prakash Marathe for this opportunity. I'm very happy to share my screen and talk about the patients with strabismus, what advances we have in the last, maybe last year or last 1.5 years. That's what I'm trying to show here. Just give me a second. That is, I have reduced the presentation, I think. Just give me a second. It should be there.
I saved another 1.5 minutes, so you can take more time.
In between, I invite our immediate past president, Dr. Mahipal Sachdev, who is here.
Okay.
Dr. Mahipal sir will be taking your talk after Dr. Ramesh.
Okay, sir. Thank you. Thank you.
Now I think it should be there, the slide.
Yes.
Thanks once again to AOS to allow me to share some of the things which we have done. Some of the things I think I have learned from others in the past 1 or 1.5 years. In strabismus, I think one of the things is we all are worried about bleeding. I don't know this. Can you see the video? Yeah.
Yes, it has started.
Yeah. So one of the things is that we use this brimonidine eye drop. It's useful in strabismus surgery. It's useful in trabeculectomy, trabeculotomy, or pterygium surgery. You can see when I put this just before GA or topical anesthesia, the whole eye becomes white. This makes your strabismus surgery or any ocular surface surgery very much kind of bloodless, so that you don't have to. When you put it, immediately the vessels blanch. This makes whole of the surgery much more bloodless, which is an important thing in any of the ocular surface surgery for the immediate cosmesis or any kind of post-operative subconjunctival hemorrhage. It makes things very much easy. And we can also put this glue, tissue glue, to close the conjunctiva so that we don't have to put this vicryl sutures. This reduces much inflammation also, and the next day patient does not have this poking sensation from this. So I would suggest any kind of ocular surface surgery, a drop of brimonidine is really good. Second thing is what we published last year. During COVID, a lot of namaste was going on. We used this surgery, this sign of namaste, so that how can it help in superior oblique tuck? Because all of us don't have a tuck available with us, tucker which is available with us. So we can use this namaste sign as one of the things.
We discuss the management of superior oblique palsy and demonstrate the procedure of superior oblique tuck. A 5-year-old boy presented to the outpatient department of our clinic with a complaint of left head tilt and outward deviation of right eye since birth. The best corrected visual acuity of the patient was 20/40 in both eyes. He had 20 prism diopter of right hypertropia, increasing to 30 prism diopter in left gaze and right head tilt. The right eye showed -3 superior oblique underaction and +4 inferior oblique overaction. Intraoperatively, Guyton's exaggerated traction test was performed with the help of P.S. Hoskins forceps, and superior oblique was found to be extremely lag. Hence, our plan was to perform inferior oblique weakening and superior oblique strengthening in the right eye. The superior oblique is approached through a superiotemporal incision. This is done to prevent postoperative scarring and to respect nasal intermuscular septum. The superior rectus muscle is hooked using a Helveston muscle hook The fibers of the superior oblique are identified with the help of an iris repositor approximately 6 millimeter behind the temporal border of superior rectus muscle. The posterior most fibers of the superior oblique are identified and hooked. The laxity of superior oblique muscle in this case can be clearly seen. We suggest a simple and easy way to judge for the amount of superior oblique muscle to be tucked, a namaste sign. In India, we greet with both hands folded and say namaste. Similarly, both ends of the superior oblique can be folded on itself as much as it allows because of its laxity, and the amount of tug can be performed where the lower ends meet. The namaste has to be full with both the lower part of the hands touching each other rather than a half namaste. A 5-4 multifilament polyester suture is used to tie the lower ends of the folded superior oblique muscle. We use a fibrin glue to seal the conjunctival ends at the end of the operation. The 9-case composite picture shows good postoperative outcome for this child.
So that's one of the surgery what we can use for superior oblique. Another thing, Stacy and we had a workshop in American Academy of Pediatric Ophthalmology, where she presented this. When you do the superior oblique tuck, for the torsion effect, you need to tuck the anterior portion. So instead of taking the whole kind of muscle, we can also do an anterior superior oblique tuck. Some of the selective patients, you can use this procedure. And the last thing about superior oblique is in Brown syndrome. We can do what you can see in the picture as Z tenotomy. With the dot, 2 dot you can see, we can cut according to that. This is a superior oblique split lengthening procedure, can be used in Brown syndrome. This is also published in BJO. This is a very, very good technique. And the last one is for Brown syndrome. This is by Dr. Visa from Spain, which is available in WSPO's website as well. Instead of lengthening, we can do a shaving procedure of the superior oblique. What you are trying to see here is trying to shave and make it thin in terms of more or less, it's similar to Z tenotomy. You can see this fibers needs to be cut. The superior oblique has to be exposed till the trochlea. This is a very, very good technique rather than doing a tenotomy. We used to do tenotomy for Brown syndrome. This is a conservative superior oblique elongation as well as superior oblique lengthening procedure in terms of shaving is one of the methods we can use to treat the Brown syndrome. So that's about superior oblique. The other thing I wanted to touch upon is monocular elevation deficit. Rather than doing both muscle transposition, we can do single muscle transposition, either medial or lateral. Superior rectus, you can transpose this lateral rectus so that we don't have to do. Along with that, we can always perform inferior rectus. Instead of 2 muscles, we are doing just, instead of 3, we can do just 2 muscles. You can see the pre-operative and post-operative, the elevation improves. You can see this patient had also esotropia, the first patient with MED, both can be tackled at the same time. So medial rectus recession, inferior rectus recession, everything can be done with one sitting. This is the pre and post-operative picture of the same thing. Instead of doing 2 horizontal, we can do a monorectus transfer. That's the modification we need to do it. Corneal surgeons do a transplantation. I think even in muscles, we can do the extraocular muscle transplantation. Already, it's an autograft, it is not an allograft. If you see this video, which we published also in APOS journal, where you can do a routine resection. And once you do the resection, this portion, whatever portion, you can keep it and transpose it to the recessed muscle, what you are going to recess. This is the resection. Only thing is in a recess resect, we have to do the resection procedure early first, and then take a bit of the muscle. Either it can be 3 millimeter or 4 millimeter. I'll come to the dosage in a bit. and then transpose it to the transplant it to the medial rectus. Here I'm trying to do the disinsertion of the medial rectus. You can see in a bit muscle is disinserted. This is the piece I have taken from the lateral rectus. The distal end of it is sutured so that you can have a longer muscle and you can have a better outcome in terms of large angle strabismus like this. Large angle exotropia, post-transplant, you can see here. Large angle esotropia, post-transplant. This is the outcome. And the last picture is a moderate angle 6-nerve paresis where we have done the transplantation. That works well. This is the dosage for these kind of surgeries where you can use. I have put 60 plus. We don't do it for a moderate angle or a small angle. We do it only for very large angle. Instead of doing 2 muscles, we do 1 muscle. This can also be done in recurrent or residual strabismus like this, where I am doing a lateral re-resection with transplantation. You can see a residual exotropia in the top picture, which is corrected after 6 weeks with the transplantation. And also you can see, does it cause any adduction, abduction limitation? Not much it causes. This is the last thing I'm going to speak. Botulinum toxin can be used as a traction suture after when we do a recess resect for the transplant. We don't have to recess resect for the third nerve palsy. We don't have to place a traction suture. We can just inject botulinum toxin for these things. So I showed surgeries for superior oblique, that is namaste sign for superior oblique tuck. I showed sparingly anterior superior oblique tuck for some of the patients. Then I showed the 2 lengthening procedure, either a Z tenotomy with suturing or a superior oblique shaving procedure. I showed monorectus transposition for monochral elevation deficit. And I showed some unique indications for transplantation. And last thing, you can use botulinum toxin as a replacement for traction sutures in third nerve palsy. Thank you so much for this opportunity, AOS and particularly Dr. Sunayana, for inviting me for this. Thank you so much. I will answer any questions.